Welcome to part 2 of this urgent 2-part series of The Lasting Mission. Mission Roll Call CEO Jim Whaley returns, this time joined by Chris Fox, Executive Director of Voices for Non-Opioid Choices. If you missed part 1 with Representative Landsman, we encourage you to go back and listen. It lays the foundation for everything you're about to hear.
Well, hello, everyone. Welcome to The Lasting Mission. This podcast educates, informs, connects, and really empowers our veterans and their families. I'm your host, Jim Whaley, CEO of Mission Roll Call. And today we're honored to have guest Chris Fox, the Executive Director for Voices of Non-Opioid Choices. Chris, welcome to The Lasting Podcast. We're glad to have you.
Thank you so much for having us. Glad to be here.
You know, before we get into the conversation, which I'm very excited about having, I think it's important that we kind of set the stage with some important statistics. And please interrupt me if you have a point on those statistics or there's a point that doesn't make sense. But the opioid crisis continues to take a devastating toll, as we all know, across the U.S. In 2022, 3 out of every 4 drug-related overdoses are attributed to opioid. Over 500,000 people have lost their lives in opioid-related overdoses since 1999. And we all know that veterans are particularly vulnerable here. The rate of drug overdose mortality for veterans rose by 53%. So let's dive into it. Let's start the journey here of the discussion. Tell me what was the passion behind, what was the reasoning behind starting Voices?
Sure. Happy to chat. So, when we launched Voices in 2019, the statistic that we would cite was that we were losing 115 Americans every day to an opioid-related drug overdose. Well, fast forward just a couple years, and today, as I sit here, we are losing 200 Americans every day to an opioid-related drug overdose death. This is despite a lot of efforts at both the federal and state level and investments, frankly, in making sure that opioid overdose reversal drugs are available in communities. Things like naloxone and Narcan are available not just in schools, but in communities and first responders and elsewhere. But also we're investing in the healthcare workforce to deal with increased incidence of opioid use disorder. We launched Voices, frankly, to, I think, attack the opioid crisis a little bit differently. If I were to be critical of the response to date of the opioid crisis, I would say that too much of the focus has been on the prevention of opioid overdose deaths, and not enough of the focus has been on how can we prevent opioid addiction in the first place. And we founded Voices with really a mission to prevent opioid addiction where we can. And for many, that can start with a prescription for opioids following an acute pain incident. And so when I say an acute pain incident, I mean an accident, a trauma, and a battle injury, obviously, a sports injury, or some kind of other incident that is episodic or short-term in nature. Today, despite all the documentaries that we've seen on cable, 90% of these patients continue to receive opioids to manage their pain. And for some, granted, it's a minority of them, but somewhere between 6 and 20% of these patients will continue to take prescription opioids 6 months later, which indicates a problem. For some, they will develop an opioid use disorder, and for some, they will unfortunately experience an opioid overdose, and some may die. And so what Voices was founded to do was to simply say, we don't need to simply prescribe opioids for acute pain anymore. And we know that there are very specific reasons for why patients are prescribed opioids, which we can talk about later. But we should be giving patients, families, caregivers, loved ones, and healthcare professionals choices in how they manage pain, which don't exist now. And we know that if we give patients some choices, we think that they would make some different decisions. And by making those different decisions, maybe we can avoid or prevent opioid addiction in the first place and save lives. And so we really founded Voices with an eye towards not boiling the ocean, not trying to solve for all of the opioid addiction crisis, but a slice of the pie. And that slice of the pie is those that might develop an opioid use pattern following exposure to prescription opioids from an acute pain incident.
Yeah. Tell me, Chris, for the viewers here listening, what are the biggest obstacles to make sure that the healthcare community and practitioners in the healthcare field understand that there's non-opioid choices, and how do we get there?
Sure. So the challenges are there's several, as is usually the case. And I think I don't want to come across and say, and place any blame. I think that we have work to do to educate and raise awareness. I think that the first challenge is that by and large, the healthcare workforce today has been trained to treat pain via prescription opioids. It's how physicians and surgeons and anesthesiologists, by and large, did their residencies. It's what they were taught to do. And I'm sympathetic because no healthcare professional wants to get a call from a patient in the middle of the night who's writhing in pain after, in surgical pain. And so they want to make sure that patients have tools at their disposal to help them, provide the analgesic support that they need. However,
Well,
as you mentioned, there are non-opioid forms of pain management that are available. Oftentimes, the challenges are economical. We know that prescription opioids are all available in generic form right now, which makes them exceptionally cheap. And because of that, they enjoy universal healthcare coverage. Put simply, insurance companies like to pay for prescription generic opioids because they're cheap, and it's a cheap way to help patients manage their pain. And so what we have to do is we have to change the cost infrastructure to make sure that practitioners and patients, and frankly, insurance companies understand what the economics are. We did an economic study just this past year that took a look at the cost to Medicare of opioid use disorder. And put simply, we took a one-year number. You cited drug overdose deaths from 2022.
like,
Well,
like,
in 2022, there were 1.1 million Medicare beneficiaries who had a diagnosis of an opioid use disorder. And we took a look at what that cost the Medicare system in 2022 and found that those 1.1 million Medicare beneficiaries ended up costing Medicare $33 billion in costs alone in 2022. And so
it's
for us,
amazing.
we need to make sure that we are removing the disincentives right now that exist to making non-opioids available. And we passed some legislation already to try to change this incentive structure. And I think there are other steps that we can do, including with the No Pain for Veterans Act and other things to make sure that everyone in all walks of life has a choice when it comes to how they want to manage their pain. Unfortunately, as is usually the case, the economics need to make sense. They need to make sense for the patient. They need to make sense for the healthcare professional, and they need to make sense for the facility that's housing these procedures. And that's what we're trying to do.
Right. I know you've done a lot of great work with Greg Landsman,
Yeah.
representative, and he was great to have on the program. And tell me a little bit about what you're doing with him, and any things in the future that you're working with him on that addresses this important issue.
Sure. Well, we passed a piece of legislation at the end of 2022 that would essentially change the cost incentive structure for non-opioids. It was called the Non-Opioids Prevent Addiction in the Nation Act. And what it attempted to do was get at the economic disincentive that
Hmm.
exists in making available non-opioids in the outpatient surgical setting. And so, if an individual is undergoing a surgical procedure, the way that we reimburse for those, at least in Medicare, is via a single payment. And so a single payment is made from Medicare to the facility that is housing the procedure. And so say you're having knee surgery at a hospital setting. So Medicare determines a specific cost for what they will pay for that procedure, and that cost is paid to the facility, to the hospital, and the hospital divides up that money to the surgeons, to the anesthesiologists. It buys whatever supplies that they need for that surgical procedure, and whatever is left over from that pot of money or from that payment is profit to the facility. And unfortunately, non-opioids are slightly less economical than generic prescription opioids, and they are treated as surgical supplies. And as such, they eat into the profitability of some of these procedures. And so what we did in 2022 is we worked with Congress to pass a piece of legislation called the No Pain Act. And what the No Pain Act would do is it would say that no more do you have to take a haircut if you're a facility that's making available non-addictive forms of pain management, and that we would make a separate payment to the facility for the use of
Right.
whatever the non-opioid was. to make up for the extra costs associated with using non-opioid based pain management. I would say the Centers for Medicare and Medicaid Services made a similar policy change starting in 2020 or 2019, I should say. The policy change was limited, however, to those procedures that happen at an ambulatory surgical center. And as such, because the majority of outpatient surgical procedures take place in the hospital setting, it was incomplete. And we worked with CMS for years and years and years. We tried to tell them that they needed to extend this separate payment to the hospital system. They were reluctant to do it. And so we went to Congress and said, we need to make the same change available to hospital patients.
Yeah.
What we
In
again,
years and years and years. That's the sentence that just strikes me, right? Wait, why is there not a sense of urgency by some of these organizations when we're talking the numbers that we were talking? I mean, if this was a storm or a disease, I would imagine there'd be a national effort behind it. Tell me a little bit about that.
the opioid epidemic has been deemed a public health emergency, and so the excuses and all, that's not a relevant really excuse in my estimation. However, there was reluctance to extend that policy change to the hospital setting, and so we had to work with members of Congress, and it wasn't a hard sell, to be honest with you. With members of Congress, we had over 50 members of the United States Senate supported the No Pain Act. And I don't know how closely you follow Congress these days, but getting 52 members of the United States Senate to agree on what's for lunch today, let alone a major policy change, it was an accomplishment I'm pretty proud of. And so we also added 125 members of the House of Representatives, entirely bipartisan, who agreed with us that we needed to do more to make non-opioids available to these patients. I will say that the legislation was limited to just Medicare beneficiaries undergoing an outpatient surgical procedure. And so it left certain patients in certain communities behind, not for any other reason other than the fact that we had to bite off what we could chew at the time. And so when we talk to what we're working with Representative Landsman on, it's really an extension of the No Pain Act and how we can make sure that more individuals can benefit from accessing non-opioids, particularly those who are predisposed to a addiction or an opioid use disorder, including those served by VA health benefits. And so what we're really trying to do is make sure that those who are trying to access a non-opioid, including those who have VA health insurance, we're making sure that the formulary that decides what products are made available to these beneficiaries covers all eligible and appropriate non-opioids. Because right now they don't. They only carry a very small subset of those products, many of which are used actually for cataract surgery and not for general analgesic support, that they at least have that option. Because right now that they don't. And so we're really working with the congressmen and members of the U.S. Congress. We'll work again this Congress to try to have that legislation reintroduced, I should say, in short order, but really trying to extend the benefits of the No Pain Act to all those served by whatever their health insurance plan, whether they are in TRICARE, whether they have VA health benefits, whether they have private insurance, to make sure that they have access to it. And then also making sure that other individuals who are, maybe not just undergoing an outpatient surgical procedure, but making sure that other patients have access to non-opioids, including those who may be trying to simply obtain a non-opioid at the pharmacy counter, that we're not making sure that those patients have to go through excessive practices or dig deeper into their pockets to access a non-addictive product.
When you think, and we talked a little bit about the numbers of increases for veterans in particular, do you have any stories or insights of a situation that really struck you as, oh my gosh, this is an example of this crisis that you can share with the audience?
The stories, I would say, unfortunately, are not uncommon. And so we have lots of stories. We talk a lot about sort of risk mitigation. And this is why state-based efforts to limit opioid prescribing don't work in my estimation. I wear a bracelet every day. I'll try to share it here. I mean, you can see it right here. This is one of my favorite stories I like to tell. It says, every day, try to do the next right thing. And this was given to me by my board chair. And it was a saying from her son, who had rotator cuff surgery when he was in high school. He was a phenomenal athlete, and as happens sometimes to athletes, they have injuries that require surgeries to repair. And so he tore his rotator cuff and he needed surgery. He would tell his mother that the first time he ever took that prescription opioid was the first time he ever felt normal. And so it just illustrates to me how certain people are just wired differently. And that when you ring that bell and you light up the brain's pleasure sensations like a Christmas tree, which is what opioids are designed to do, it can have ramifications for people. Not all, not even the majority, but it can have some ramifications. And so we speak to people all the time, veterans and those in other walks of life who have had an injury and have had surgeries that have had consequences. We have the husband of one of our other board members, had shoulder surgery, biting a
Oh,
belt
God.
because he's in long-term recovery from a substance use disorder, and he didn't want to be re-exposed to a narcotic. And so the stories will break your heart about the lengths that people will have to go through to try to get access to a non-addictive therapy. The icing on the cake, I will say, for my board chair in the story I told about her son is her daughter a couple years later, despite the fact that she ultimately would lose her son to an opioid addiction that took him down towards heroin and recovery and ultimately relapse and death, is his sister, her daughter, would also suffer the same injury years later. And the stories that she would tell about the lengths that they went to make sure that she was not exposed to opioids, not because of a lack of trust or faith, but just they'd lived that experience before about what happens when a child goes down that path and they were not going to go down that path again. Again, they break your heart. And so, unfortunately, we hear these stories all the time. And
Yeah, and I think a lot of people believe or think that well, that could never happen to me, right? But we all know the saying, "There by the grace of God go I." And I am sure there's someone that's going to listen to this podcast or share this podcast with someone that knows someone, or maybe it's them that thinks, "Well, I may be starting to have a problem with these opioids."
yeah,
What would you tell them they need to do?
You know, um, I would share a personal anecdote here as well. You asked for stories. The moral of the story, I think, is that there is no shame or no blame in having an addiction or having a problem here, but that we need to be our own best advocates for ourselves and for our family members. Because I remember a couple years ago, my son, who was 6 at the time, was having his tonsils out, and I remember a conversation with a nurse practitioner at the time, who was saying to me that she was going to send him home with a rescue dose of some opioids. And I politely told her that that was not something that I was interested in for my son. And she looked at me almost like I was a negligent parent. How could you? She said. And I said, we're going to be fine. He's going to have ice cream and ice pops, and he's going to be managed through just fine on NSAIDs and acetaminophen. But the story I tell is not one of pride or one because I'm trying to pat myself on the back, but rather I'm hopeful that more patients can have the wherewithal to push back, as I did that day. And I think that day is not too far off in the near future. That there is a day where we will be arming more and more parents, loved ones, caregivers, and others with the information and the tools they need to ask the right questions before, during, or after surgery, and that we can have the wherewithal. But hopefully, if somebody's watching this and they may be saying, hey, I don't feel that great, if it's been too long before I've taken medicine, I would hope that they would reach out to a medical professional and seek help, because there is no shame here in asking for help. And I will say that there's a big community of folks who understand exactly what that plight looks like and are eager to help. There are a lot of resources that are out there to get the help that people need.
Yeah, wonder what a wonderful message that, there's no shame in that. To have this addiction, as you stated, everybody reacts to chemicals differently.
Mhm.
Everybody's head is wired differently, thank God.
Mhm.
And so your reaction to these things and propensity to be addicted to it is different between every person. Anybody who's known anybody that's gone through any kind of an addiction um, knows that it's overpowering. It's next to impossible to swim against that tide.
Yeah.
And so certainly as a community, we should be empathetic to each other And I love your idea of let's make sure people are armed with knowledge. I
Mhm.
mean, you go back and read a military or a medical textbook or see the practices 100 years ago, and you're like, oh my gosh, what
Yeah.
were they possibly thinking with lobotomies and all kinds of things,
Mhm.
right? To address issues. And of course, that was the best and brightest at the time.
Yeah.
But if you didn't push back and say, well, that doesn't sound right, you could easily be wrapped into be giving a prescription that may not be needed. Could be, you could have a reaction to it,
Mm.
and I think it is important to talk to families and friends and others and figure out there's a community here, is what you're saying,
There is.
to find help. And I just want to make sure people that are listening understand that, and they can contact through us through our website, and we can get you to the right people here.
For sure.
Pretty soon we got a new administration coming on board.
Mhm. Yep.
A new secretary of the VA is taking over. Um, let's say you get an opportunity to sit down with him and talk to him about what's going on here. What would be the 2 or 3 takeaways you'd want him to know about this, and what he could do?
Yeah, I think first and foremost, I would say that, medical practice has evolved, as you mentioned. We know better about what the risk profiles of prescription opioids now than we did in the 90s, when, prescribing looked much differently. I will say
Mhm.
that, again, to give some credit where it's due, opioid prescribing in the country, measured by number of opioid prescriptions dispensed every year, is down about 50% since 2010, when we dispense now roughly 125 million opioid prescriptions every year in this country, which may be a lot. Maybe you don't think that's a lot. Maybe you do.
Yeah.
But at its heyday, we were dispensing about 250 million prescriptions for opioids every year. And so, because medical practice is evolving and we know better, and frankly, we are telling practitioners, and I'm sympathetic, we're telling practitioners that they have to do more with less. We're telling practitioners that thou shalt not prescribe more than X days worth or X number of pills to these patients. And we're not giving them, in many cases, tools in their stead. And so, what
Right.
I would say is we need to be doing more to enlarging practitioners' toolboxes. If we're going to take away a tool that they've used for years and years, that is, their prescription pad for opioids, we should be giving them other tools to help them manage their patients' pain. And we have the ability to do that now. But unfortunately, there are some barriers that get in the way, and we need to be removing those barriers. And we at Voices stand ready to work with you to help you identify what those barriers are and to knock them down, to help you identify exactly what the solution is and how we can work together to make the solution make sense for others. And so, I would say right now we have it's a new day in the post No Pain Act world. That is the law of or the rules of the road right now. There's more work to be done. I would also tell them there's been a lot of ink devoted recently to some improvements that we've seen in overdose and opioid related overdose deaths recently. I would say let's not pat ourselves on the back too soon. Now is the time to put our foot on the gas here and really double down. I think one of the troubling trends that we've seen is that some of those reductions are not seen across the board. And in fact, we're seeing in older Americans a 9% increase in the number of opioid related overdose deaths. And so we need to better understand exactly what's working. And let's double down on an opioid addiction prevention strategy, because I think that has the opportunity to pay dividends down the road rather than I liken the strategy that we've adopted to date as trying to pull drowning victims out of the river. This opioid overdose death prevention strategy is, again, trying to save drowning victims who are already drowning. And so, what I would say is let's focus a little bit more on how we can stop people from falling in that river in the first place, because I think
Right.
there was tremendous promise for us to be able to have some additional impact there.
Well, when you look at these numbers
Hmm.
and the extent of the deaths and overdoses, the math tells you it strikes just about every family, every extended family for sure. So everybody has a vested interest to make sure that we provide veterans and everyone else the opportunity to get other pain medications. And to your point, if you're going to take those tools away from a doctor and you have a loved one who's in severe pain and can't sleep and can't even think, you're going to want something to help alleviate that. We want to provide that for them. Otherwise, they're going to find it on their own. And it's
Yep.
probably not the best avenue for that. Tell me a little bit about how the audience here can help and be supportive of you and your mission.
Yeah. So our mission, first and foremost, is to promote policy change. And they say all politics is local. And so on our website, which I don't know if it's inappropriate or not, but I'll plug it if that's
Oh,
okay,
no,
which
absolutely.
is
We want to support it.
okay, which is www.non-opioid choices. Be careful. Opioid has two I's. It's OPIOID, non-opioidchoices.org. We have an action center, and on that action center is the opportunity for individuals to weigh in with members of Congress. All you need to do is put your name and your address and your zip code, and there's a message that you can send about, and that will get sent directly to your members of Congress, both in the Senate and the House, and letting them know about your interest and urging them to do more to make non-opioids available to, you know, military families and retirees and others. And so you can visit that website now, visit our action center right there, and go and help spread the word. Let them know about your interest in removing some of these barriers. And so, we say at Voices that we very much believe in the power of the collective. And as our name states, I believe that 10 voices are more powerful than five, and five more powerful than three. And so, if you're interested and you want to, hop on board. We very much are an inclusive group. And so there is more information on that website, including how you might be able to get more involved if you want to do more than just simply fire off a letter to your congressional delegation. We're always seeking additional folks who want to share their personal story, whether that's in local media or on Capitol Hill with members of Congress. And so you can find us on that website. We're not hard to find, and come along for the journey with us.
Well, it's interesting how much our missions are aligned in amplifying the voices of families, veterans, and the veteran community on important issues like this. And when we talk about loss of life, and we talk about suicides, and we talk about homelessness, there's a lot of important challenges that organizations like yours and like mine need to tackle. And the only way we're going to do that is by the support of the veteran community. And there's 18 plus million veterans out there. And think about it, if 18 million veterans are having their voices heard all at once
Yep.
about an important topic, and we're going to get people to listen. Thanks so much for today. Really appreciate you taking time with us, but more importantly, love what your mission, and really value what you are doing. And we know you're changing people's lives, saving lives. Um, what's one last message or point that you'd like to leave with the folks?
I would just like to say that, we have shown that we can have an impact, and we've shown that the best way that we can have an impact is going at it together. And so, I would say that the enactment of the No Pain Act, frankly, showed us exactly what can happen when we come together under a common cause. And I think it shows that there's opportunity for us to continue that work. And like I said, to put our foot on the gas here and double down on opioid addiction prevention strategies. And I hope you'll join us as we do this and share in our success.
Chris, thank you so much. And thanks to your team and everything that you're doing. Look forward to talking with you and working with you to tackle this important subject.
Of course. Thank you, Jim. Thank you for having us.
Thank you.